We basically send patients home with the printed instructions of the things they can and cannot do after surgery, and with exercises they're supposed to do. And also Loretta, my physical therapist, she keeps in touch with the patient's own physical therapist at home and kind of monitors their progress and tells the physical therapist what to do.
What are the medications people are using chronically for this or inacutely?
So patients use medications, specifically for the nerves would be either gabapentin, the Neurontin, or Lyrica, the pregabalin. I do believe that patients need appropriate pain management to prevent that central sensitization or to reverse it. So they need pain management. They need narcotics.
How high a dose of narcotics are? I know spinal cord injury pain. There's you need high dose narcotics to really help the neuropathic pain from spinal cord injury. What kind of doses are these patients requiring to maintain their function?
Oh, I've seen patients on really large doses, either methadone or oxycodone, long-acting strong. I leave that up to whoever is doing patient's pain management. The other medications that patients often use is Cymbalta, which is an antidepressant, but it works pretty well for chronic pain.
Effexor,
as far as muscle relaxants, the one that I really believe it works, it's a compounded suppository of 5 milligrams of Valium and 4 milligrams of Baclofen, and it's a vaginal suppository, and as far as pelvic floor muscle spasm, I think it works better than anything else. The other suppository that seems to help is Belladonna and Opium, the BNO suppository. Those are not compounded, they actually are available at the pharmacy. They tend to be more expensive though. There's a device called InterStim, which is actually made by Medtronic, and it is made for urinary urgency and frequency. It is not really approved for pain. However, there is some physicians right now around the country that start placing the InterStim, not how it is intended to be placed into the S2, S3 foramina in the sacrum, but they're placing it into the Alcox canal next to the pyramidal nerve, with fairly good results. And this is actually the procedure we will start doing in our practice, just to add to all the other things that we're already doing.
So that's a non-narcotic modality that can potentially help pain long-term in a patient who has persistent pain after decompression.
Correct. I think there's a small percentage of patients that are completely pain-free. I believe that about 70–80% of patients with all the procedures we do are better as far as pain goes. Even after all these procedures, very rarely we eliminate the pain completely.
Tell us about your experience with the depression, how these problems are affecting the family unit.
So whenever I come in the room to see a patient with pyramidal neuralgia, and let's say it's a husband and a wife, and the wife is the one with pyramidal neuralgia pain, I almost always do that. I kind of jokingly say, entering into the room, "So who is the patient?" And almost every time, both of them say, "I am." What it tells me is that the husband is, or the other family counterpart, the spouse, is equally affected by this, even though that's not the person with pain, but that person is equally affected. Complete lack of sexuality. It is not only that intercourse, intravaginal penetration that hurts, but a lot of these women have pain with sexual arousal, and even the thought of intercourse or a thought of any thought that gets them aroused will cause pain. Patients are absolutely debilitated by pain caused by mesh, and a lot of them are even suicidal.